Peptic ulcer disease arises from imbalance between defensive factors and aggressive factors. Defensive factors are mucus, bicarbonate, mucus blood flow, and aggressive factors are acid, pepsin, NSAIDs, Helicobacter pylori. HCl is secreted by gastric parietal cells due to stimulation of H plus K plus ATPase, that is proton pump. Histamine through H2 receptors, acetylcholine through M1 and M3 receptors, and gastrin through CCK receptors are important stimulators of proton pump. Acetylcholine and gastrin exert their action directly as well as through release of histamine. Antral G cells produce gastrin on stimulation by dietary peptides. Gastrin mainly stimulates release of histamine from enterochromaffin-like cells and weakly stimulates proton pump itself. Parietal cells secrete H plus in lumen through H plus K plus ATP, that is proton pump. Vagus nerve via acetylcholine helps in increasing acid by three mechanisms: direct stimulation of proton pump, stimulation of enterochromaffin-like cells to release histamine, direct release of gastrin by action of G cells, and inhibition of somatostatin by action on D cells. Later inhibits release of gastrin. The main strategies employed for treatment of peptic ulcer disease and gastritis are: first one, neutralize gastric acid by antacids, decrease secretion of acid in stomach, increase protective factors like mucus and bicarbonate, protect the ulcer by forming a layer over it, stimulate the healing of ulcer, kill H. pylori associated with peptic ulcer disease. Antacids. These drugs are weak bases that neutralize gastric acid, do not decrease volume of acid secreted. Their major role in peptic ulcer is to provide prompt relief from ulcer pain. Antacids may be systemic, absorbed from GIT, or local, poorly absorbed. Sodium bicarbonate is rapidly acting systemic antacid. It is not indicated for long-term use because it releases CO2 that can cause belching and gastric distension. Ulcer perforation can occur. Sodium chloride formed in the neutralization reaction can be observed that can exacerbate fluid retention in patients of congestive heart failure and hypertension. Systemic and urinary alkalosis may occur. Rebound hyperacidity can occur. Aluminium hydroxide, magnesium trisilicate, megalrate, magnesium hydroxide are non-systemic antacids. These are slower but longer acting drugs. Rebound acidity does not occur. Aluminium hydroxide causes constipation, whereas magnesium salts are responsible for diarrhea. Most of the market preparation contain these agents in combination to minimize the impact on bowel movements. Simethicone is a water repellent, pharmacologically inert anti-foaming agent. It reduces flatulence and can also be used to prevent bed sores. Antacids decrease the absorption of acidic drugs. Acidic drugs are ionized in alkaline medium and tetracyclines by forming complexes. Milk alkali syndrome, hypercalcemia, renal insufficiency, and metabolic alkalosis may be caused by excessive doses of Na2CO3, sodium bicarbonate, and calcium carbonate with calcium containing foods like milk. Drugs decreasing acid secretion. They are proton pump inhibitors, potassium competitive acid blockers, H2 receptor antagonists, anticholinergics. Proton pump inhibitors. These are prodrugs. Active moiety is sulfonamide and act by irreversibly inhibiting H plus K plus ATPase in gastric parietal cells. The drugs in this group include omeprazole, pantoprazole, esomeprazole, lansoprazole, rabeprazole, tenatoprazole, approved in Japan, elaprazole, approved in Korea. These drugs are weak bases and can be destroyed by gastric acid. To protect them from gastric acid, these are given an enteric coated tablet. This coating dissolves in alkaline medium, that is intestinal juice, and prodrugs are absorbed. On reaching parietal cells, active moiety sulfonamide is formed and gets trapped. These can inhibit both basal acid output, that is nocturnal acid secretion, as well as meal stimulated acid output, maximal acid output. Tanatoprazole is a very long acting proton pump inhibitor and can effectively suppress nocturnal acid secretion. Proton pump inhibitors are given orally in early morning empty stomach just before breakfast. Pantoprazole, omeprazole and lansoprazole can be given IV. These drugs have short T half-life but can inhibit acid secretion for more than 24 hours. Hit and run drugs inhibit proton pump irreversibly. Proton pump inhibitors are the drugs of choice for peptic ulcer disease due to an etiology, even NSAID induced. These are also the agents of choice for GERD and Zollinger-Ellison syndrome. For prevention of stress-induced gastric bleeding, H2 blockers IV infusion are preferred over proton pump inhibitors. In patients with nasoenteric tube, immediate release omeprazole by nasogastric tube is currently preferred. Proton pump inhibitors are quite safe drugs and have diarrhea, headache, and abdominal pain as adverse effects. These have been shown to be carcinogenic in rodents, but no such case has been reported in humans. All proton pump inhibitors are substrates of CYP2C19 and CYP3A4 except rabeprazole. Proton pump inhibitors can also inhibit these microsomal enzymes leading to drug interactions. Particularly important is their interaction with clopidogrel. Later is a prodrug which is activated by CYP2C19. Omeprazole and other proton pump inhibitors inhibit this enzyme and result in decreased activity of clopidogrel. Rabeprazole followed by pantoprazole has minimum risk of drug interactions. Long-term use of proton pump inhibitors is associated with subnormal vitamin B12 levels, that is reduced absorption, increase in risk of hip fractures, reduced calcium absorption, increased risk of enteric bacterial infection, Clostridium difficile infection, bacterial gastroenteritis, pneumonia. Lansoprazole is most potent proton pump inhibitor. Lansoprazole is safest proton pump inhibitor in pregnancy. Lansoprazole most potent, lansoprazole safest in pregnancy. Rabeprazole is fastest acting proton pump inhibitor. Rabeprazole has minimum inhibitory effect on CYPs. Potassium competitive acid blockers. These are the drugs that inhibit proton pump by competitive binding to potassium site of proton pump. These are reversible drugs and duration of action of these drugs depends upon their half-lives. Vonoprazan, approved in Japan, Revaprazan, approved in Korea, are important drugs in this group. Major advantage of these drugs over irreversible proton pump inhibitors is that they cause very fast acid suppression. H2 receptor antagonist. These drugs competitively inhibit H2 receptors in parietal cells, thus inhibiting the acid secretion. Acetylcholine and gastrin act partly by causing the release of histamine. Therefore, acid secreting capacity of these agents also is decreased by H2 blockers. Drugs in this group are cimetidine, ranitidine, famotidine, roxatidine, nizatidine, loxatidine. These drugs are more effective for reducing basal, that is nocturnal acid secretion, histamine mediated, than stimulated acid secretion, stimulated by gastrin, acetylcholine as well as histamine. These drugs can be used for GERD, peptic ulcer disease, Zollinger-Ellison disease, and prevention of stress-induced ulcers. Cimetidine is not used routinely because it can cross blood-brain barrier and result in mental state changes. It inhibits binding of dihydrotestosterone to androgen receptors that can manifest as impotence in males. It inhibits metabolism of estradiol and increases serum prolactin levels on long-term use. Thus can cause gynecomastia in males and galactorrhea in females. It is a potent inhibitor of CYP enzymes and can increase plasma concentration of warfarin, theophylline, and many other drugs. It is least potent H2 blocker. Famotidine is most potent H2 blocker. All H2 blockers except famotidine inhibits the gastric first pass metabolism of ethanol. Loxatidine is a non-competitive blocker of H2 receptors. Nizatidine also possesses anti-acetylcholine E activity and can cause bradycardia and enhanced gastric emptying. Nizatidine is having negligible first pass metabolism, that is 100% bioavailability. Anticholinergics. Non-selective antimuscarinic drugs like propanthyline and oxyphenonium can be used for decreasing gastric acid secretion. However, by increasing gastric emptying time, these drugs prolong exposure of ulcer bed to gastric acid. Further anticholinergic adverse effects like dry mouth, blurred vision, constipation, and urinary retention are commonly seen with these drugs. Pyranzapine, telanzapine are selective M1 blockers that are preferred antimuscarinic agents for peptic ulcer disease, as these are devoid of anticholinergic adverse effects. Drugs increasing protective factors. Prostaglandin E1, E2, I2 act as anti-ulcer drugs by increasing the release of mucus and bicarbonate and by increasing the mucosal blood flow. Prostaglandins also inhibit H plus K plus ATPase and decrease the acid production. Misoprostol, prostaglandin E1 analog, is the most specific drug for treatment and prevention of NSAID-induced peptic ulcer, drug of choice and prevention of NSAID-induced peptic ulcer. Drug of choice is proton pump inhibitor. Enprostil and rioprostil, prostaglandin E2 analog, are other drugs in this group. Commonest side effect of prostaglandin analogs is diarrhea and colicky abdominal pain. Ulcer protective agents. These drugs form a covering over the ulcer bed that prevents its exposure to gastric acid. Sucralfate and colloidal bismuth subcitrate are two important ulcer protective drugs. Sucralfate. It is aluminium salt of sulfated sucrose. At pH below 4, its molecules polymerize to form a sticky layer that covers the ulcer base and acts as a physical barrier to prevent acid exposure. It can bind phosphates also and can result in hypophosphatemia. It should not be given with antacids because it acts only in acidic medium. Antacids raise the pH by neutralizing the gastric acid. Most common side effect of sucralfate is constipation. Colloidal bismuth subcitrate. It also forms an acid-resistant coating over the ulcer. It also dislodges H. pylori from the surface of gastric mucosa and kills it. Adverse effects include blackening of tongue and bismuth toxicity, osteodystrophy and encephalopathy. Rebamipide and icabet are cytoprotective drugs acting by increase in prostaglandin generation and by scavenging reactive oxygen species. Sucralfate, cross-linking at pH less than 4, coating of mucosal defects. Ulcer healing drugs. Carbinoloxone. Carbinoloxone is obtained from the roots of licorice. It causes epithelialization of ulcer without decreasing acid production. It can displace aldosterone from plasma protein binding sites and result in hypertension, sodium and water retention, and hypokalemia. Anti-Helicobacter pylori drugs. H. pylori infection can be detected by urea breath test. It is responsible for relapse of peptic ulcer disease. Drugs used for treatment of H. pylori include metronidazole or tinidazole, amoxicillin, clarithromycin, tetracycline, colloidal bismuth subcitrate, omeprazole, lansoprazole. Triple drug therapy for H. pylori is clarithromycin, amoxicillin, proton pump inhibitor. CAMP. Treatment of choice for H. pylori eradication therapy. Areas with low clarithromycin resistance. Standard triple drug therapy. Clarithromycin 500 mg, amoxicillin 1000 mg, metronidazole 500 mg if penicillin allergy. Lansoprazole 30 mg twice daily for 14 days. Areas with high clarithromycin resistance, standard quadruple drug therapy, lansoprazole 30 mg BD, bismuth subcitrate 120 mg QID, tetracycline 500 mg QID, metronidazole 500 mg TDS for 14 days.